Professor Burra.
Yes, thank you very much. Thank you very much, Professor Newton. Really very grateful. I would like to thank you for this invitation. Thank you to Professor Ramadori for having proposed this webinar. And as I said, I will try to show you how some epidemiology is changing together with the risk factors for the HCC. Just a few information that we probably all know about the impact in terms of burden of liver cancer. The primary liver cancer is the 7th most frequently occurring cancer in the world. And it is the 2nd most common cause of cancer mortality. And we know the majority of liver cancer is HCC, accounting for at least 75% of tumors. And if we look at the distribution all over in the world of the liver cancer, this is a nice picture referring to the estimation for 2018. In blue and dark blue, you see the countries where the incidence is much higher. And some countries belongs to the North America, South America, Africa, and Asia in particular. In fact, let's say that the highest incidence is found in Asia and Africa. It is very interesting, one single country, Mongolia, has the highest incidence in the world with 94 cases, 100,000 population. And it is also interesting to assess the combination of the rates of cancer together with the number of populations, so the largest population in the world, which is China. So the combination of two factors makes China having the greatest number of cases overall. What about what have we observed in the last 20 years in terms of trends in the incidence? Some countries where we have reported an increase in rates, some other countries fortunately decreasing rates, and it depends where we start from, low rate area compared to high rate areas. But just to show you, to make it easier to understand, this is the estimation comparing at least 30 years with an increasing rate in India, for example. If you look at the United States, again, we have an increasing rate in the last 30 years. This is also the case in New Zealand and Australia. But then we have in Europe some countries where the incidence is declining. For example, just took Italy and France, that we have very similar approach to the treatment of HCC. That said, the other issue is that the program of HCC is very poor. This is why we are talking a webinar on liver transplantation. And that results in a very similar rates if we compare incidence and mortality. Again, coming to the estimation for 2018, if the cancer rate is 9.3, the mortality rate is 8 point, a little bit higher than 8. So again, you will see that the similar 8.5 to 9.3 confirm the high risk, the poor prognosis for hepatocellular carcinoma. What about the age? Usually the age change according to the different countries. In US, they reported some data on the evaluation of the median age diagnosis for male population between 60 to 64, female population 65 to 69. I will talk to you later in my presentation about one of the reasons why it is like this. But then we can look at another big continent such as Africa. You see one country, Egypt, may have median age of cancer 58 years of age, and some other countries 46, which means 12 years earlier. And this is confirmed also in the relation and the ratio between male and female. We always say that HCC will develop 2 to 4-fold higher rate in men compared to women. And this is confirmed in Europe, France, the ratio is 5, Malta, the ratio is 5 nearly. But if you look at some other countries, it changes quite a lot. So the ratio is much closer to 1, similar in countries in Central America, South America, and also in Africa. But then according to what Nuto told me, we should really, and he actually introduced that in the key words and the key concept that he summarized, is the relationship with the etiology and underlying liver disease. And I will present to you some data about hepatitis B, hepatitis C, alcohol-related liver disease, and non-alcoholic steatohepatitis. As a hepatologist, we all know that HBV is associated with action promoting mutation of hepatocytes because it is linked with the necro inflammation of the liver, and the action will be the mutation liver cells. And during lifetime, usually the risk to develop cancer is seen in between 10 to 25% of people. And we know also that there are several cofactors. And the cofactors are summarized in at least three main fields of interest. One are the demographic characteristics. Some of them are alluded before. There are viral factors, which includes the replication of the virus, genotype, the duration of infection, and co-infection. And there are some other environmental factors that I will describe later that can be can really increase the risk of HCC, regardless of the etiology of HBV, but also in HBV. What can we do? Usually we have to work on the underlying liver disease using the nucleoside and nucleotide analogs. It has been demonstrated that can reduce the risk of HCC. They do not completely eliminate the risk of HCC. That's why the surveillance should be performed in cirrhotic patients, and despite that they are treated with the nucleoside and nucleotide analogs. One study from the United States confirmed that when entecavir tenofovir was given to patients, they show the 5-year HCC risk reduced in patients with cirrhosis, despite it was still higher comparing to patients without cirrhosis. And we also know that cirrhosis plays a role in the risk of HCC. The other important message is that when we have this condition, these factors, together with the age, also the level of decompensation, meaning the platelet numbers or the presence of diabetes, are surely the cofactors can be incorporated in risk scores to predict the development of HCC. And together with the treatment, we should anticipate prevention of HBV and therefore prevention of HCC with the vaccination. This is an interesting study from Taiwan, where they follow up a cohort of newborn for 30 years, demonstrated that in 30 years of vaccination, they reduced the risk of cancer by 80% and the mortality due to cancer by 92%. What about hepatitis C? Again, HCV infection is definitely a risk factor for HCC, with inducing damage of the hepatocyte and regeneration, inducing fibrosis, and increasing risk by at least 10 to 20-fold. Overall, today, it seems that HCC, that data before the new antivirus, ranges between 0.5 to 10%. But it's interesting to see, as I said before the introduction of VAs, that in US, they had an increase by 130% between 2 decades, 1990 to 2000 and 2010, more or less. Again, similar to HPV, also for the HCC, we have that the risk factors for development of hepatocellular carcinoma include gender, ethnicity, viral factors together with the co-infection, but also include some other risk factors such as the metabolic risk factors. But the clear message is that once we reach the sustained virological response, this is the only factor, the main factor that really decreases the incidence of HCC. And together with that, we have to consider not only the treatment, but also the different phase of the life in the gender-based population. So if we look at the efficacy of the drugs and the evolution of the liver disease, but also of hepatocellular carcinoma in male and female, these are studies that were run in Italy by the group of Erika Villa on the effect of estrogens and androgens. The liver has some receptors for these hormones, and this is why it's very susceptible to changes in hormone levels. It means that in the fertile period for the women, we have the protection by the estrogen, but then after the menopause, the women will lose this protection, and then the women will have over 65 years of age the same risk that we see in the population. We should therefore try to reduce the risk, treating the patient whenever indicated with the new drugs, overall, we are talking about reducing by 50–80% in people that will achieve SBR. In this study, they show that the risk of HCC was reduced in a cohort of patients who achieved SBR by at least 76% in 5 years, with the incidence of HCC reduced less than 1% per year. And this is clearly an impressive result. Is alcohol a risk factors? Yes, it is. For heavy alcohol consumption, the association with increasing risk of HCC, vice versa, with a low alcohol intake, it seems to have a decreased risk for HCC, but it's not the alcohol. Again, we have to look at the other metabolic diseases, in particular diabetes. And this study showed that in non-diabetic patients, there was a further decrease by nearly 1/3 of the risk of HCC. So again, not only one risk factor, but some other factors. And also, again, for the alcohol, the gender should be evaluated. We know that female are at higher risk to have acute alcoholic hepatitis, to have liver damage, for the difference in alcohol, the hydrogenase activity, and for the trend to be to have a higher rate of cirrhosis, and therefore, as shown in the heavy drinking pattern, the alcohol was associated with a 4-fold increase risk of HCC in women and 60% increase of HCC in men. But maybe, as Professor Tonuto anticipated, we are now discussing about a new etiology of liver disease, which probably much more developed in the US. I will show you comparing to Europe, and it is the non-alcoholic fatty liver disease. We are now discussing about the new nomenclature, but let's say that according to Zoba Yunussi studies, 25% overall is the presence of steatosis within the population, which is some higher incidence in different countries. But what is really impressive is this prediction, this study in the annual incidence of NAFLD-related HCC in the US. Estimated 5,000 cases in 2015 and 1,200 cases in 2030. It means an increase by 137%. And this is the list of countries being evaluated: China and Japan in Asia, France, Germany, Italy, Spain, UK in Europe, and US. And you see the discrepancy. There are 47%, for example, estimation of increase in Japan, comparing to 130 in the US. In fact, in the US, there is another paper where they showed that today the prevalence of NAFLD is about 1/3 of the population, similar in men and women, a little bit higher in some different ethnicity, Mexican Americans, for example, but quite similar between whites and blacks. But since we are discussing here the risk factors, NAFLD has really something quite peculiar to this disease, since we are used to see the development of HCC in patients with cirrhosis. In the case of NAFLD and NASH, in a pre-cirrhotic condition, we can have the risk of development of hepatocellular carcinoma. And in fact, these recent papers show that this is the estimation, say, of the incidence of HCC, starting from the NAFLD population, which is quite low, and these are mainly studies based on liver biopsy. Then we have quite a high rate of incidence in patients with cirrhosis. But then in the middle, we have the NASH population, in whom it's quite rare that we perform liver biopsy. And so it's difficult to predict, but this is quite an assumption about that the risk will be considered in the middle between NAFLD and cirrhotic patients. Let's say that according to different studies, we can consider a range between 0 to 30% of NAFLD-related HCC, which develop in the absence of cirrhosis. And some study reported definitely 2.6-fold higher risk when the NAFLD patient has diabetes, obesity, dyslipidemia, and hypertension, comparing to the same NAFLD patient without these features. Why? Because metabolic syndrome is associated with increasing risk by 81% in one study. Diabetes is associated with increased risk of HCC that has been reported similar to 2 to 3-fold at least. Obesity, even in a younger population, adolescent, in the early ages, is associated with the risk of HCC later on in their lifetime. So what about when we have the pre-cirrhotic, when we have NASH? As I said, it's difficult to have the numbers. This study reported 12 to 40% of HCC developing pre-cirrhotic liver disease. And if we compare NAFLD and NASH, NAFLD seems to account for a larger proportion of cases non-cirrhotic compared to cirrhotic HCC, 26 versus 30%. And NASH, the same, seems to account for a larger proportion non-cirrhotic, ranging from 20 to 50%, comparing to what we describe, definitely less than 10% in other liver disease, such as the reference was in this paper, the HCV. And then the clinical presentation, surely in this case, we observe that the HCC developing patients at least between 5 to 10 years old. They are associated, as expected, with a higher presence of metabolic risk factors. And then this is probably due to the indication that we have for the surveillance, the diagnosis is made at more advanced stages, but I will discuss about the surveillance later. We try to evaluate some other factors. This is a group of special interest group of the Italian Association for the Study of the Liver. So we reviewed recently all the papers published on this issue about the risk of HCC according also to gender. And we found an interesting paper in this, and we discussed that if we consider the female population, we just discuss about the losing the protection of the estrogen after the menopause. But there is another risk that's, let's say, HPV treated with controlling the HPV infection, but then becoming menopause woman will develop also some metabolically mediated, let's say, liver damage due to the increase in intra-abdominal fat with atherogenic lipid profile, steatosis, insulin resistance. So sometimes it's rather difficult really to separate the different risk factors. And on the top of everything, a genetic genetic has been listed by Professor Newton in his summary. Despite we know that the same gene that are associated with development of steatosis and steatohepatitis are also associated with cancer. However, in principle, they can be very useful in the prediction of the at risk, high risk, let's say, individuals. But then in practical way, this genetic polymorphism will account for a small proportion of liver cancer. So not so. Is not useful for every category. And I like this summary from the same paper that was recently published, all the risk factors that have been reported so far to show how we can move from NAFLD to HCC and are useful in the, but also in the pre-cirrhotic NAFLD to identify the risk categories for this development. Of course, we should treat the complication drugs that they may be associated with reducing the risk of HCC, such as statins and metformin, whereas some other drugs, at least in a couple of studies, being shown not to be so protective. So, should having that said, that should we really then go ahead with the screening in those patients when they have only steatosis, let's say in brackets only steatosis? ISO guidelines say, of course, we have to follow up a patient with cirrhosis and suggest considering surveillance in patients with pre-cirrhotic fibrosis. AGA, very similar recommendation. ASLD guidelines, they stay on the HCC surveillance for the setting of, only in the setting of cirrhosis, but do not recommend even to consider the surveillance in patients with fibrosis. So the proposal is then to try to create a sort of risk calculator. This is a nice study, was published a couple of years ago, where they identified 7 predictors: age, sex, diabetes, BMI, platelet, albumin, AST, ALT ratio. But that was performed in patients with cirrhosis, so it's difficult to translate the same application in patients without cirrhosis, with NAFLD or pre-cirrhotic NASH. So the same proposing now a combination of some other factors together with fibroscan, together with biochemistry, plus risk factors that are being really described, the effect of medical therapy, and of course the genetic polymorphism by using artificial intelligence. And in this way, maybe in the near future, we can have better information on the predictors of this evaluation. Before ending, just to mention a few things. Don't forget, in some population, we have other risk factors that are environmental, such as the aflatoxins. And I wanted to show you this data because if aflatoxin per se will increase the risk of HCC by 6%, and if HBV alone will do the same by 11-fold, look at the combination of the two in some countries where there is an epidemic for the HBV and aflatoxin. So we have to keep in mind for those populations. Iron intake can be at risk. Some countries in Africa have the tradition to drink iron-rich beer, and the iron intake, high iron intake, has been associated with increased risk for hepatocellular carcinoma. And finally, the tobacco. The cigarette is associated with an increasing risk of liver cancer. The good news is that for individuals who stop smoking more than 30 years, the risk is similar to that of never smokers. The only protection is given by the coffee. So let's say at least we have one good news. That is not new as an information. We know that the coffee is associated with decreased liver of diabetes, of liver cancer. Not clear about all the mechanism underlying this protective effect. However, surely this is associated with the caffeine itself, but also to other components of the coffee. So I think as a take-home message, we have seen the several factors associated globally with the risk of HCC still today. The surveillance is important in people as to these risk factors. And the etiology of liver disease and the treatment of underlying liver disease should be always considered. And I think I interpret the process to everyone that we have epidemiological data, but we need to combine basic science studies more on this topic and a better genetic evaluation for the predisposition. And thank you very much for your attention.